I'm the lead pharmacist for the Michigan Collaborative Type 2 Diabetes. I'm also a clinical pharmacist in family medicine at Michigan Medicine. I work under a collaborative practice agreement that allows me to prescribe for diabetes, hypertension, hyperlipidemia. Patients are typically referred to me by their primary care physicians and mostly for type 2 diabetes. I see about 6 to 9 patients per half day. I have no disclosures to report. So Blue Cross Blue Shield of Michigan established and funds statewide collaborative quality improvement projects across the state of Michigan. But the really unique thing about this is that they're developed and executed by Michigan physicians. Despite the funding line, though, the CQIs are all payer, all patient initiatives. Thus, for performance metrics, these are based on physicians' entire panel. Prior to MCT2D, the vast majority of CQIs were in the space of acute care, so surgical, procedural. So it was MCT2D was the first one to involve primary care physicians at a population level. So typically CQIs start small, say a hospital. But MCT2D, we came in and we brought in September of 2021, 25 physician organizations from across our state, and then they enrolled 238 primary care practices, along with collaborating endocrinologists and nephrologists. MCT2D identified 3 initiatives that we want to help to improve across our state to improve the care of diabetes. So those include increasing the prescribing of GLPs and SGLT2s, expanding the use of CGMs, and then supporting the use of lower carbohydrate eating patterns. So since we were a new CQI and our participants were new to CQIs, our really first goal was getting to know our participants. We wanted to understand their confidence from not only a high physician administration level, but down to individual practices. We were interested in their confidence, but we were also interested in really understanding their anticipated barriers so we could take action to help them with their needs. We employed a mixed method approach. So we started off, with 25 interviews with the physician leadership. Then our team compiled the interview transcripts and looked for themes that we could prioritize barriers that we needed to address. Once we enrolled the practices, we then sent an electronic survey to each clinical champion within the practice to assess their confidence in our initiatives and implementing our initiatives. Finally, we analyzed those confidence responses across various practice demographics listed here on the slide. So one of the things that we found most interesting in interviewing our leaders was what they thought the most common challenges were to their practice. And for any of you out there that practice in primary care, this probably looks familiar. Physician schedules are packed. Access is difficult. Resources, whether it's just staff, we're losing nurses and MAs, but then also resource of time to do data reporting and whatnot. And finally, while the coverage of SGLT2s and GLPs has improved, I think navigating the insurance complexity is a challenge. And so we acknowledge this and we're ready to start helping with that. And then finally, regarding CGMs, I think I could spend the rest of the hour talking about the challenges in getting CGMs covered. But again, I don't have an hour, and I think we all know that. So despite these barriers, our practice champions were confident that they could implement this in their practice. As you can see on the far right of the screen, they were most confident in implementing the low-carb diet patterns, and they were least confident in implementing CGMs. Not so shockingly after what I just discussed. So when we then dialed into the clinical champion responses and looked across various practice demographics, we looked at employed And independent practices, the independent practices were more confident. We think that's due to the fact that they have more autonomy and can really affect change in their practices versus employed. When we looked at safety net practices, again, not surprising, safety net were less confident. I think that gets to their patient demographics. And finally, regarding an employed pharmacist, I think it's important to keep in mind our sample size is pretty small. There's actually few practices that have a clinical pharmacist, and the way we worded the question might not have gotten to what we were looking for. So I think in future direction, we're going to look to adopt that question. So as a coordinating center, we've been actively listening to feedback from our POs and practices. We form a patient advisory council to address patient activation. We've lowered some of the physician requirements to address burnout because of COVID. We've created tools, cost, insurance, low carb to help the physicians implement low carb. And if you want to visit our website, mcteaching.org, you can see them all. And then finally, we work with Blue Cross Blue Shield of Michigan to utilize a statewide data hub to kind of take that burden of data reporting off the practices. So to wrap up, over the last 9 months, we got our toes wet. We got to know our participants, and we've been providing resources to promote their success. We offered CE trainings to every physician in every practice across all 3 initiatives. Starting this month, we're collecting case studies from every physician in every practice against one of those initiatives just to get information, build our baseline metrics to then establish future metrics moving forward. And then finally, what I'm most excited about is I'm going to be hosting a monthly virtual session where any participants from POs or practices can drop in and ask me questions to offer support to those practices that don't have a pharmacist. So I thank you so very much for your attention. I hope you'll stop by tomorrow.
This is not